Cardiovascular disease prevention is a key priority for health systems and is an area we are focusing on as one of our clinical priorities as the HSN Network. Since the inception of the HSN Network, we've worked in a number of areas of CVD prevention, notably atrial fibrillation. And our focus at the current time is on the lipid management pathway. As a stroke physician, we put a lot of focus on implementing secondary prevention after TIA or stroke. And that has mostly been on blood pressure control and anticoagulation of those people in atrial fibrillation. And improving cholesterol management has been somewhat of a Cinderella aspect of our work. And I think that's also mirrored in primary care and in cardiology. Yet we have convincing evidence that intensive control of cholesterol, lowering LDL, gives major benefits. And that's why we have this joint AHSN Network Accelerated Access Collaborative Lipid Program working across the whole pathway. So in primary care, we have a major focus on treating high-risk patients with high-dose intensity statins for secondary prevention, to use ezetimibe, another generic drug, to achieve better control in those not controlled on statins alone or unable to tolerate a statin, and to make full use of the newer treatments that are available, specifically inclisiran, PCSK9s, and bempedoic acid. With inclisiran, we have a very novel deal between the health service, NICE, and the company in terms of getting early access at high value discounted costs to achieve population health benefit. Cardiovascular disease is a major driver of healthcare inequalities and is one of the 5 elements in the Core 20+5. So our program is also focusing on making sure we engage with those communities and practices which have the worst outcomes. But it's not just about primary care. We also need to be using the acute stroke and cardiac pathways to help achieve intensive control in those people who are very high risk immediately after an acute coronary syndrome or TIA or minor stroke. And we've established a national working group of leaders across the different pathways and including primary care to really come together to agree clear, simple guidance to accompany the existing NICE pathway that has been put together. In addition to better treatment of those people with known high cardiovascular risk, we're looking in the innovative child-parent screening program for familial hypercholesterolemia operating in half of our academic health science networks to identify children and their families with FH to ensure people are treated before they develop premature cardiovascular disease and are dead or disabled in their 40s and 50s. So this builds on high quality clinical trial work undertaken some years ago by David Ward and colleagues, and is in partnership with the Genomic Medicine Services, and is a really excellent example of deploying genetic medicine to give population benefit for a condition that affects 1 in 250 people. So we hope you'll gain increased understanding of what other colleagues are doing across the region in improving the lipid management pathway. Always focus on developing clinical leadership and new models of care that will operate efficiently in primary care. The idea of blood pressure hubs can also be, for example, extended to administering some of the newer cholesterol lowering drugs. But if we achieve successful control of cholesterol with LDL lowering in a high-risk population, that will deliver massive benefits and savings in terms of heart attacks and fatal and disabling strokes that are prevented.